Good morning, and welcome to the 15th of our Town Hall series today. As always, this is sponsored by our Society for Leading Medicine. I'd like to thank each of them for their support and for sponsoring this, and I'd like to thank the chairs of our society, Jeremy and Caroline Finkelstein and Catherine and George Masterson. As always, thank you for all of your hard work and dedication to Houston Methodist. You'll notice a small change today as we move on in the studio here. You know, we've had spacing based on CDC and our own internal guidelines so that we've been shuffling people in and out so we never have more than 3, and now with the revised guidelines and our own internal guidelines and the progress we've made, we're able to have all 4 of us at the table here, which is really nice today. Speaking of those 4, we'll be hearing from Dr. Dirk Sostman a little bit later. We'll also be hearing from Dr. Niravath, who is in our Houston Methodist Cancer Center and heads up our Cancer Survivors Clinic. But first, we're going to start to my right with Dr. Brian Miles, who holds the Centennial Chair in Urologic Oncology, and he's going to talk to us about men's health, and it's very, very well timed given that June is Men's Health Month. Thank you, Dr. Miles.
It is, but of course a very important month is September, Prostate Cancer Awareness Month. That's what I do, Mark. Thank you for allowing me to speak. COVID has impacted us all significantly, some of our friends and neighbors more substantially. We're getting the disease. Thank God no one I've known has succumbed to it. But I'd like to talk a bit about, just briefly, urologic, what happens in the urology clinic since we've been visited by this virus. You know, this is an experience that all areas of the country have experienced, some much more than others. And I'd like to share with you 3 slides in a moment. I think missed one. Back up of my thoughts, but as with all aspects of medical care, the virus has changed our world in dramatic fashion. There's fewer clinic visits at the time. These have gotten back to normal now. Fewer surgeries, the isolation from one another, and to share with you some of the things you may have read, usually in the newspapers, about urology and the virus. It was found in erectile tissues, so you'll see a lot of things, especially on the Kardashians, about loss of erectile capacity due to the virus. This was on 2 patients who were treated at University of Miami in Florida, and they had erectile dysfunction. They were putting in a penile prosthesis, sent some tissue off, and found viral particles in those 2. They had severe erectile dysfunction, and the message was, perhaps this is due to the virus. There's really no data to support that. It's just 2 patients, and we'll need to follow men who have had the virus to see this. It's also been found in semen in a handful of patients. Again, it has not been shown to be transmissible in semen at all. So I'd like to share with you experience throughout the country, a report from the Association of Community Cancer Centers. What this is talking about, they've surveyed a number of cancer centers, and what's happened with the staff during all of this? Well, it's strained resources, it's isolated us from our patients and often isolated us from one another, which has had a profound impact on morale in many centers throughout the country. I'll say in appreciation, if nothing else, for our institution. We have been on top of this from day one, been involved in research from day one, and the communication from leadership to faculty to nurses and MAs has been profound, and I don't think we've had much of a morale issue except that it's gone up, if anything. It has changed how, for a while, we would see patients. This was virtually, over the phone or on a teleprompter, if you will. Not so great for urology, especially cancer. You need to examine your patients. It's really hard to examine them over the television, over a Zoom meeting. Certainly simple blood studies can be done. Those sort of things can help, but it's difficult. It also had a significant impact on my particular research in getting patients on to clinical trials because they weren't coming to the hospital at all. Due to fears of the virus coming to the office, we had it isolated so you could only have a certain number of patients. But in most cancer centers, the staff have shown remarkable resilience. Certainly that's true in our institution, and we've done everything we can to help our patients and comfort them and get them more comfortable coming into the office. So in urology care, especially cancer care, we suffered significantly due to the limitations of surgical prioritization and patient fears. We could only do a certain number of cases for good reasons, but also by mandate from the government, because we needed personal protective equipment protected. You could only do so many cases because we had to have a baseline minimum amount of this gowns and things for not only in surgery, but throughout the hospital. So you couldn't go below a certain level. So we couldn't do all surgical cases. And we didn't want to admit patients because the hospital tried to keep the census low because of the possibility of an overwhelming number of patients with COVID coming in. So we had to prioritize cancer patients, those who really needed surgery, got it. Outpatient surgery generally got it. That didn't lose much of an edge for outpatient surgery. Stone disease patients would only come in if they were in extremis, if they were really hurting, because they would usually have to go through the ER, and they didn't want to do that. So routine urologic care was compromised by our ability not to see patients in the office and not to do surgery. Interestingly, andrology and low testosterone managed to hold their own. A lot of this you could do over virtual visits, but this was pretty critical to men. And we have a large international population who seeks our expertise. They unfortunately were not allowed to come in, leave their own countries, or come in easily to the United States. So they were down significantly, which is unfortunate for many of those patients. The thing that bothered us in urology, and I'm sure all other specialties, were many serious issues beyond the virus beset our patients, okay? So patients would have symptoms that we would want them to come in immediately for, but they were terrified of getting the virus, so they would avoid the doctor's office or the emergency room. A few of these would be hematuria, blood in your urine, flank pain, which could be due to a stone, but it could be due to kidney cancer. Difficulty or inability to urinate, called urinary retention, which has profound effects on the kidney. And of course, other things non-urologic, like coughing up blood, breast lumps, these things people would put on hold. And we noticed, I'm showing a picture here of a patient with a renal cell cancer and what's called a caval thrombus. On the left side of the screen, you can see a large, ugly-looking mass, and up top looks like a balloon coming off it. That is a tumor thrombus or tumor clot that's heading up toward the heart. There's a schematic here. If you look on the left one, you'll see that goes all the way up to the right atrium. Normally in a year, we might see 6 to 8 of these patients. In the first 3 months of this year, 4 months, we've had 6. I recently had one who stayed at home. He had blood intermittent flank pain, but was so worried about getting the virus that he decided that perhaps he should wait until it's safer. And instead, he is in a difficult position now, much like this other patient who had almost daily blood in the urine. The arrow's pointing to a large, what looks like white area. That's a big lob of cancer encompassing most of the bladder. He came in with a hemoglobin of 6. He was getting a little lightheaded and finally came in to the office. I admitted him right away. A hemoglobin of 6 means he's down to very little blood in his system. And this cancer also had locally spread to the lymph glands and other areas of the pelvis. So he certainly avoided the virus, but he compromised his health in other ways, because this is not going to be curable, and he's been having this problem for a year. Had he come in sooner, we may have been able to do a lot more. We certainly will make every effort at this time. So in urology, COVID-19 has had a significant impact on healthcare throughout our country, but unfortunately, fears of this virus, I think, created what I call collateral damage. Patients just not understanding, and perhaps that has to do with us too, not helping them better to understand, or our political leaders that don't sacrifice all aspects of healthcare because you're afraid of the virus. So we have to educate our patient population not only about global disease issues, but the need to not ignore other important aspects of their own health, because other things can hurt them as badly as the virus. And thank you, Mark.
Well, thank you, Brian. Very much appreciate that report. And you heard that common theme that we've seen throughout the last year of people delaying and avoiding some medical care because of COVID, and then unfortunately suffering the consequences. Are you seeing that continue, or do you think that now is getting better as we obviously are getting to a better point?
It is definitely on the downward curve. Still some trailing in who finally are more comfortable. Usually these are people who've gotten their vaccine, so they're now more comfortable coming in. I had one recently who doesn't want to get the vaccine and has been ignoring some pretty substantial blood in his urine. He's got a bad cancer.
Yeah, I mean, unfortunately, we've seen this throughout this pandemic. We as human beings are really bad at assessing risk and weighing risk. We see that with the vaccines now, of course, and decisions around that. We've seen that with people avoiding health care when they were having chest pain, or when they're having blood in their urine, or other things that are serious kind of alarm symptoms that require immediate attention. So, well, thank you for updating us on that. Dr. Niravath, you're going to talk to us a little bit about breast cancer. Thank you for being here, Dr. Niravath.
Yes, great. Thank you for having me on. So I'm very happy to be speaking with you all today about some various breast cancer updates. I'm actually going to talk to you about a few different topics. I'm going to first talk a little bit about how some of the breast cancer screening issues relate directly to COVID in terms of the optimal timing between having your COVID vaccine and then getting subsequent mammograms or breast ultrasounds that we often get for annual screening. And then I'll close by speaking a little bit about exactly what the cancer survivorship program here at the Houston Methodist Hospital really has to offer. I think a lot of folks may not be fully aware of the program that we have here for cancer survivors. So to begin with, I'm going to actually start with a case history, which is something we do all the time in medicine. We like to think in terms of real people. So this is just a fictional person that I'm using for the purpose of explanation. So Janice is a fictional 52-year-old lady with hypertension, diabetes, family history of breast cancer, a fairly healthy person otherwise. Her mother had breast cancer when she was 49. Her maternal aunt, meaning her mom's sister, had breast cancer at age 52. So this means that Janice's risk of breast cancer would be slightly elevated above that of the general population. So she's also been taking hormone replacement therapy with estrogen and progesterone for the past 6 years. This is also something that is quite commonly done among postmenopausal ladies, but definitely can increase the risk of breast cancer, especially if it's taken for many years. The longer that we stay on hormone replacement therapy in postmenopausal years, the higher that risk of breast cancer becomes, unfortunately. And she is wondering, when can I come in for my annual mammogram? This is about time for her to come in. And she decides, okay, I'm going to come in. She's been given good advice that this is a great time to come in. And then this is what her mammogram shows. Now, I know a lot of us don't look at mammograms every single day, unlike me. But what we're seeing here, the arrow on the top is actually pointing towards this conglomeration of lymph nodes that are actually under the axilla, or in the armpit. Now, many times when we see abnormal lymph nodes like that, it is concerning. That can be signs of many things. Obviously, the first thing we want to rule out is a potential breast cancer, which can move to the lymph nodes. So this is typically an alarming symptom. There can be other things, however, that can cause this. Things like infections or lymphoma, inflammation or irritation, or in this case, it very well could be related to the COVID vaccination, for example. Now that we're having such a mass rollout of these COVID vaccinations, obviously many people are getting vaccinated. So as luck would have it, many women are then subsequently coming in for their mammograms, and we're finding this axillary lymphadenopathy. To be quite honest, in the beginning of this vaccine rollout, I think many of us in the breast oncology community, the radiologists, breast oncologists, and surgical oncologists, were honestly kind of figuring this out as we went along. Because this had never really been done before on this scale, where everyone is getting vaccinated at the same time. But we commonly see these lymph nodes, and the question is, do we work them up? Should we be waiting to get mammograms at a later time? What is the best way to manage this ambiguity that tends to come up? So I'm going to talk about that a little bit here. So the first question is, should we be concerned? And thankfully the answer is no. In most cases, when somebody's recently gotten a COVID vaccine and we see a mammogram or a breast ultrasound that's showing enlarged lymph nodes like that, this is the body's normal healthy immune response. So obviously the vaccine is intended to cause an immune response so that we can fight off the vaccine if we were to be exposed to it. And the lymph nodes on the same side where you've received the vaccine is where the majority of that immune response is going to happen. So this is all good things that are happening. It just means that you're doing exactly what your body is supposed to, and it's not a concern. However, from a breast cancer standpoint or from a mammogram standpoint, it can lead to unnecessary additional imaging or sometimes biopsies, because typically, if this was not in the era of COVID vaccination, if we saw those types of lymph nodes, we would move on to an ultrasound, a diagnostic mammogram, and we would get an axillary lymph node biopsy. Now, obviously, if this is just a normal immune response, which is going to be gone in a few weeks, all of that is clearly unnecessary. We know that the highest incidence of these types of enlarged lymph nodes after vaccination tends to happen about 3 to 10 days after, but that can be definitely prolonged for many ladies, which we'll talk about in a few minutes here. So in general, the recommendations that we make is that anytime that we see enlarged lymph nodes on mammogram, an axillary ultrasound is a clear next step. The reason is that the axillary ultrasound can really tell us if these look to be healthy lymph nodes, which are just enlarged, or if they appear to be pathologic, because pathologic lymph nodes, which do contain cancer, have different characteristics. So the ultrasound can really help us differentiate and kind of put somebody on more of a biopsy type of path where this may be something concerning, or more of a let's repeat this in a few months when these changes have most likely resolved. So not everything necessarily needs to go to biopsy, and ultrasound is a great way to differentiate those two. Now, especially if we call it lymphadenopathy or enlarged lymph nodes. If those enlarged lymph nodes are seen on the same side as the recent COVID vaccination, and there are no breast abnormalities on that mammogram, then the general recommendation from the Society of Breast Imaging is that we can repeat the imaging 6 to 12 weeks after the final injection. And if the lymph nodes are no longer seen, and again, there's no breast abnormalities, there's no further follow-up required. And if there is clinical concern, then of course we would always proceed with the biopsy for lymph node confirmation, but as a last resort. So we're definitely trying to avoid repeated healthcare exposures, unnecessary tests, and unnecessary anxiety. So, in the case of Janice, you may be dying to know what happened to her. So, y'all might have noticed that on that mammogram there was a second arrow lower than where the lymph nodes were, because in that particular case, she had also a small 6 millimeter right breast mass and the enlarged right axillary lymph nodes. So she went to a breast ultrasound to better understand what was going on. We also would take into account in this fictional patient her high-risk features. For example, the family history, the fact that she took the combined hormone replacement therapy, and that abnormality on mammogram. So she did have enough features to actually take her to biopsy. Thankfully, the breast biopsy and the axillary lymph node will hopefully come back negative in such a patient. But that's somebody who we would take her whole picture into account in general in terms of deciding how far to go with her. So ideally, the best advice that we can give is that even if you're due for a mammogram, we're not recommending delaying mammograms for a very long time, because, as we often say, cancer does not wait, unfortunately, for the virus to be done with its inexorable course that it's been taking. So we still do recommend getting the mammograms, but ideally, if we can just time the mammogram to be about 6 to 12 weeks after the final vaccination, that would be ideal and probably help avoid any confusing features that we may see. However, if you have a breast concern now, so meaning if you have a breast lump, if you have anything abnormal that you're feeling, changes on the skin, redness, dimpling, puckering, nipple inversion, these are all red flags, and please do not delay your mammogram, even if you just had the vaccine. If you have something very concerning, we would want you to come in immediately. And if possible, one other option that's actually a recommendation, including from the CDC, is that you can obviously choose the opposite arm. For example, if you're a breast cancer survivor and you're particularly concerned about one side mammogram, because local recurrences can sometimes happen on the same side as your previous breast cancer, you can purposely choose the opposite arm, which we would typically do anyway for breast cancer patients. And then finally, you can also even use the thigh. So the kind of upper part of the thigh off to the side can also be used for a vaccination site if you know that you're going to be having a vaccine and you will be having a mammogram soon as well. So that is also one option. I'm going to move on now to speak a little bit about our cancer survivorship program and hopefully just give you all some information about the resources that can be available. So first of all, some brief words on what is a cancer survivor to begin with. So a cancer survivor is actually anyone who's been diagnosed with cancer literally from the time that they're diagnosed for the rest of their life. And cancer survivors are important for many reasons. This all became really relevant when we first started learning about cancer treatment and cancer side effects with people who have Hodgkin's lymphoma. So this cryptic picture that I'm showing here, that large cell in the middle is actually a Hodgkin's lymphoma cell. So we realized that for people who had Hodgkin's lymphoma, what we were finding is that we were doing a great job of curing Hodgkin's lymphoma for many years now. The vast majority of patients with that cancer are thankfully cured, but unfortunately they would go on to see many other side effects later as a result of their therapy. So you can see this graph here showing that after people have moved on from their Hodgkin's, the biggest cause of death, even more than Hodgkin's lymphoma, far more than Hodgkin's lymphoma, was actually a secondary malignancy, meaning a new cancer that they may have developed from the treatments that we've given them. So we know that some chemotherapies, including some types of, as well as some types of radiation, can cause secondary malignancies. Also, our treatments can sometimes cause heart side effects. So some folks, depending on the type of treatment they received, can have more risk of arrhythmias, heart attacks, or atherosclerosis in the heart. So obviously we realized that we may not be doing people a favor, we might be over-treating them because so many people are being cured and yet we're finding more problems down the road. So this was kind of the birth of the cancer survivorship movement in general. Realizing that all these different side effects, including in the lung, as well as quality of life side effects, things like dry eyes and mouth, hypothyroidism, needing thyroid replacement for the rest of your life, infertility. So not everything is fatal, but obviously everything will affect quality of life. So now there's a much more, a bigger focus on this. So just to give you an idea of what cancer survivorship has done over the years, in the old days when somebody came in with Hodgkin's lymphoma, even if it was a very small lymphoma that was just localized to the neck, for example, they would actually get radiated in what I'm showing on the far right there. Basically, would do something called mantle cell radiation, which includes the entire neck, the thyroid, the lungs, the heart, the axilla, the breasts, and all of that radiation later was leading to these higher risks of lung problems, heart problems, thyroid cancer, breast cancer, the list goes on and on. And so we've now moved to doing just involved field radiation, which is much more appropriate and yielding the same level of cure, but lower risk of these long-term side effects. So for example, somebody that comes in now with that same type of neck-involved lymphoma only will only receive radiation to the neck alone, thereby sparing all these vital organs that we were otherwise radiating in the past. And we see that the long-term results are far superior to what we were getting before. And this becomes especially relevant because, as you can see, as we go on, we're only getting better and better at curing many types of cancer. So Hodgkin's lymphoma is one of the early success stories of highest cure rates. But now I can say that many cancers have gotten to be so much better. The advances that have been made, for example, in breast cancer, lung cancer, melanoma, just to name a few, have been remarkable. And so we're seeing more and more cancer survivors, which means that we could be potentially seeing more of these long-term side effects that we're left to deal with. So This is a graph here that shows that for folks who've had cancer, which is shown in the red line there, we can see that they're having a lot more side effects from their treatments, especially related to the heart. And our goal is to bridge that gap. So meaning that rather than seeing this increase in late and long-term cardiac and other side effects, we're hoping to bring that line down to the general population. So meaning just what we would expect to see generally. The ideal treatment would obviously be something that treats the cancer only and does not leave somebody with these long-term dangerous side effects. So to give you all an idea, in something more that I do every day, another case history of a patient who has had breast cancer. So Alma is a 47-year-old woman who works as a VP at an oil and gas company. She is married with 2 kids, ages 15 and 12. She enjoys long distance running, traveling, mentoring, clearly a busy lady who has many things in her life. She was diagnosed with breast cancer 1 year ago, is now in remission. At that time, she was treated with chemotherapy, mastectomy, and radiation. So in that first year, we find that many patients will come back with several questions, and these are just a few of them here. Many ladies who are taking hormone-lowering medications notice that they kind of feel like an older lady. They have joints that feel achy and stiff. They may ask, why am I tired all the time? Why am I taking all these naps? This is not me. I'm usually a go-getter. I can't remember quite as much as I used to. This is a very frustrating one for folks who are especially used to functioning at a high level. So for example, you might walk into a room and forget why you walked in there. You open the fridge and you forget what you were going to do. Or you're multitasking and you can't remember to do all the things at one time. You kind of forget to go back to what you were doing. Energy can be low. Like for example, many people find that they can't do quite as much exercise as they used to do. Hot flashes are a major problem, which can be very frustrating. Libido is often something that suffers for long-term breast cancer survivors. So obviously this just creates a lot of frustration. People wonder why, if their cancer is gone, why are they not feeling like they used to? And I think only recently in the medical community have we really given all of these symptoms the importance that they truly deserve, understanding that quality of life is something important, and we're trying to get this back for cancer survivors. So just to give you all an example, we have many clinical trials that we're doing at the Cancer Survivorship Center that are looking at trying to understand how we can actually improve these side effects in a safe way. So number one, by hopefully de-escalating therapy in some cases, and number two, by treating the side effects that we have created. So for example, we have a clinical trial called the REVIVE clinical trial here, which is specifically meant for postmenopausal women who are taking an aromatase inhibitor, which is a medicine that many women take with breast cancer. It lowers estrogen in the body, and it often causes vaginal dryness. So for these women, we are randomizing them to either receive vaginal estrogen or a vaginal moisturizer called Replens that contains no hormone. This is kind of actually a revolutionary idea, even though it may not sound like it on the surface. The reason being that for many years, oncologists were terrified to give vaginal estrogen to anybody who had an estrogen-positive breast cancer for fear that the estrogen could be fueling a potential breast cancer recurrence. Data has actually not ever borne that out. So this clinical trial is looking at giving vaginal estrogen to patients and very carefully monitoring their estrogen levels to see if we truly are seeing any peak in estrogen or any higher risk of recurrence later on. And thankfully what we're finding at this point is that the estrogen level really does not peak. It does not seem to be systemically absorbed in the blood, but the vaginal estrogen is a far superior treatment thus far to the Replens. So meaning that women are actually finding relief from this. Most of them are wanting to continue the vaginal estrogen beyond the period of the trial. The trial goes on for about 6 months, and most women are so happy with this that they often want to go on it for even longer. And what we're showing is that in general, like I said, there's very minimal estrogen absorption. We're seeing less vaginal itching and discomfort, definitely less pain with intercourse, improved libido. We're also normalizing the vaginal pH, which is something we're looking at in this study, because the pH can often make the vaginal tissue hospitable to different types of bacteria. So you can get more infections, whether they be urinary tract infections or different types of vaginal irritations, or vaginosis we call it. So in general, overall, the benefits of survivorship care are that we're looking at preventing cancer recurrence and new cancers, and we're also looking at these late and long-term side effects, managing them appropriately with multidisciplinary care, and hopefully improving quality of life. So in general, just some of the ideas that some of the services that we offer through the survivorship program. We have dietary services, which patients tend to love, about educating people about healthy food and how to go about having a healthy diet. Physical medicine rehab, getting our strength back. Stoma care for people who need it, meaning colostomies or other types of special stomas that people have. Speech therapy, and then we involve many specialties, including neurology, cardiology, and so forth. We also have psychological services, including things like music therapy, sexual therapy, chaplains. So really kind of looking outside the box there. And then social services we also offer. This is important for cancer survivors. It can be very financially toxic to go through cancer therapy. So we're also looking at helping patients get through many of the FMLA questions, employment rights, and so forth. And then we also have complementary medicine available. So this is, we actually do have acupuncture that we offer, massage, yoga. We have exercise classes, meditation, mindfulness. Many patients are not aware of these services that we have. So I hope that now, knowing about all of this, I hope that you all will take advantage of these services that we have. Thank you.
Thank you, Dr. Niravath. So just a couple clarifications for people out there. So if somebody's had cancer, they have an oncologist they follow with. This is in addition to that, so they would typically get referred into the clinic with you or your colleagues?
Yes, exactly. So that's a great point to make, that yes, whenever you're seeing a cancer specialist, you would keep your same oncologist. But if you're having specific survivorship problems, then very often the oncologist will refer them to see me. And then I can hopefully direct them towards one of the clinical trials that we may have for the problem that they're having, but they would still continue to see their general oncologist and get survivorship care at the same time.
Great. And one other, I guess, a series of questions. We got a few come in through the internet about breast cancer in men, asking about, is it the same disease as in women? How is it treated? What's different when we do see breast cancer in men?
Okay, so yeah, breast cancer is actually rather rare in men. It's about 1% of all breast cancer cases, but we do see it. Actually, breast cancer in men most commonly mimics the breast cancer that we see in postmenopausal women. So it's typically estrogen positive, and we usually treat it with many of the same medications that we use in women. Most commonly we use tamoxifen because this is the one that's been studied the most. And it's the one that's the most effective at lowering estrogen for men. Whereas the aromatase inhibitors, which we can also use in women, don't tend to work as well in men, partly because they have higher testosterone levels, so the estrogen level won't get quite as low for them. But in general, yes, most of the treatments are extrapolated from women to men.
Great. Well, thank you very much for that. Okay. Well, thank you. And Dr. Sostman, we're going to turn to you and hear a little bit update about COVID-19 vaccines and treatments.
Very good. Thank you, Mark. Really appreciate these talks from our colleagues, Dr. Miles and Dr. Niravath. Really interesting, and again, part of our gradual transition away from COVID back to the full panoply of medicine. So I'm going to follow up with a little bit more on vaccines, and a couple of questions about drug treatments came in over the internet, so we'll talk about that a bit. I'm not even going to talk about safety today because the news on safety has been so good for so long, there's really no point in harping on it any longer. Likewise, the overall data on, real world effects in different countries, whether it be in the Middle East, in the UK, in Europe, or here in America, the real world data of, millions and millions of people who've been vaccinated is really just very, very darn good. Maybe not quite as good as the measles vaccine, but almost. Reductions in asymptomatic infection, reductions in symptomatic illness, reductions in hospitalization, and reductions in death. This is really the one thing that has unequivocally gone right during this COVID pandemic. Some data from the CDC, they've stopped updating this in the same way, but really I think this tells the story. Comparing vaccinated with unvaccinated incidence of infections, the rate of infections in vaccinated people was about 1% that in unvaccinated people. The rate of hospitalization in vaccinated people was about 1% of that in unvaccinated people. And for death, it was even 10 times better than that. 1 in 1,000 times better for death if you've been vaccinated. The other question, which I think we talked about a bit last time, was, do you really need 2 doses? The answer from our very, very careful study of our own employees and co-workers is absolutely yes. 1 dose is protective. It's certainly not even close to as protective as 2 doses. And we also don't know how long 1 dose is going to last. So definitely get your 2 doses. A lot of questions about prior infection. If I've had COVID before, am I protected? Do I need to get vaccinated? Do I need both doses of the vaccine? Should we allow people back into the office if they're not vaccinated but they've had COVID in the past? And a good way to summarize the data that's coming in is it's protective but not as protective as vaccination. People have looked at clinical follow-ups, they've looked at sequential measurements of antibodies, and the data really indicates that previous infection with COVID significantly reduces your chance of getting reinfected. But it is not as good as getting vaccinated. For example, in the study that was done by the public health authorities in England, although the chance of getting infected again was about 83% less than if you had never been infected. Some people, even who had been infected, who had anti-COVID antibodies, still had high virus levels in their noses and could be transmitting it to others. The good news, based on the immunology measurements, is that it seems like the duration of immunity is going to be really quite good. The long-lived memory cells that can be recalled and rapidly produce antibodies seem to be very persistent and very common after infection. And cell-mediated immunity as well is apparently very robust after you've had COVID. Now, all that being said, we don't really exactly know what's the best test to measure to tell if you are protected, or having a test exactly what the level of that test ought to be in order to say you're safe, you're not safe. The thing that we measure typically is antibodies, and that's not only because it makes sense, but also because it's easy to measure. And the correlation there seems to be pretty good. If you look at the graph on the left-hand side of the slide, the bottom axis is the dose of the messenger RNA vaccine, and the vertical axis is the level of antibodies. And this is a logarithmic scale, so each one of these tick marks is a factor of 10. And you can see that as the dose of the vaccine goes up, so does the level of antibodies in the blood. And if you look at the right-hand panel, basically the same kinds of scales, they're actually measuring virus neutralization. And that correlates with the level of antibodies. So given that neutralizing antibodies are a very rapidly acting and very effective counter to the virus, this does seem like a very good correlative protection. Problem is, at this stage of the game, we don't know what titer is sort of the cutoff. Now, these two graphs are a little complicated, but take a look at them. You can get this material, we send it out. Take a look at them, and they tell a really interesting and really good story. So the graph on the left has basically three comparisons. One is people at baseline who, in the green dots, have not had COVID, and in the purple dots have had COVID. The middle panel, green dots and purple dots again, had COVID, not had COVID, after a single dose of vaccine. And then the right-hand panel after a second dose of vaccine. And again, this is a log plot, so factors of 10. If you have not been vaccinated, but you have had COVID, you have about 100,000 times as many antibodies in your blood as somebody who has never had COVID. After the first dose of vaccine, a person who's never had COVID will get the same level of antibody protection as somebody who's previously been infected. But somebody who has previously been infected will get an even higher level of protection by about a factor of 10. However, after the second dose of vaccine, the non-infected person will have the same level of antibody protection as someone who has had COVID and had a dose of vaccine. And the person who has been previously infected is not going to do any better. So I think this is not official guidance. Don't try this at home, but I think most people are feeling that if you've had COVID, probably one dose of the messenger RNA vaccine is really going to be all you need. Similar data on the right-hand slide, where they looked at people who have been infected and are then vaccinated, people who have not been infected and are then vaccinated. And here they also looked at the SARS-CoV-1 virus, the original SARS virus, as well as a couple of the variants. And what they found was that if you've had COVID and you get vaccinated, your level of antibody protection is about 10 times that of somebody who's had a dose of vaccine but has never been infected before. And that's even against the SARS-CoV-1 virus. So the combination of previous infection and vaccination is kind of like a superpower. The duration of antibody levels appears to be good for at least 6 months. Probably it's going to end up being more like more than a year. And that is borne out by the 6-month follow-up of the Pfizer vaccine clinical trial patients, where it's just as effective against COVID-19 6 months in after the vaccination. So fantastic news, excellent stuff going on. What could go wrong? The thing everybody talks about, and it's a justifiable worry, is the viral variants. We have some good news here. First off, if you look at the red box, the B117 UK variant, which is now also called Alpha, is still more than 85% of the isolates in Houston, Texas that we're measuring. That's good news because that variant is pretty well covered by all existing approved vaccines. When you start to get into some of the more exotic variants, like the South African variant or the Indian variant number 2, Some of the other vaccines, such as the AstraZeneca vaccine, appear to begin to fail. The messenger RNA vaccine, at least the Pfizer, which has been more extensively studied, but I think this is going to apply to the Moderna as well. So far, from a clinical infection standpoint, appear to cover the South African variant and the Indian variant. Great. The caveat there is when they do lab studies and they measure antibody levels and the ability to neutralize the virus, all of these vaccines are less potent in the lab against these variants. So I think the way to interpret this is that the more the virus changes, the less recognizable it becomes to the original vaccines, but that the level of antibodies that the vaccines produce is so good that it's able to overcome that lesser potency of recognition. At some point, there's going to be a crossover, and unless the virus runs out of room for mutation, in other words, if it mutates anymore, it won't be able to function. Unless that were to happen, at some point these vaccines are going to need updated vaccines and boosters. And we have not so far seen any evidence whatsoever that the virus is running out of mutation room. All these mutations seem to make it more capable rather than less. So although there's been some discussion in the press about, we're not ever going to need boosters, or, it's going to be 5 years before we need boosters, I don't know if it's going to be a year or 2 years or 3 years, but I feel quite strongly that we're going to need boosters. Moderna has already started to look at this, and I won't go into this data in any detail, but it's shown that they can provide tailored booster shots that are exceptionally good at particular variants. And they can also mix these with the original vaccine to cover the original variant, and both of these produce very, very good antibody responses. So, and the great thing about the RNA vaccines is they can be updated really fast. So, although the variants are obviously of concern, I think there's really no reason to panic about them. They change slowly, and we can respond and adapt. A lot of questions came in about people with solid organ transplants or other kinds of immune suppression. And really, I'm sorry to say, this is a group of folks that the FDA has so far not served very well. And with solid organ transplants, just like with other vaccines, at best you can expect maybe a 50% response rate to vaccination. Older patients, more recent graft procedures, mycophenolate or rapamycin analogs, and people whose grafts are not functioning well are all at higher risk for poor vaccine response. So if it's possible, you should get all your vaccinations updated before transplantation. If that is not possible, there are maneuvers that could be tried. We don't have a lot of data on them. Try to defer the vaccination for a few months after transplantation. Possibly use a higher dose. Boosters. And one thing that's kind of interesting is, let's say you get the Moderna vaccine and you don't get antibodies. Some people who then turn around and get a booster dose with a different vaccine, like the J&J, end up responding. Again, this is all totally anecdotal. It's absolutely not sanctioned by the FDA or any other august professional society, but people who are in this situation are trying these things, and in some cases it seems to work. Getting your vaccine not in the muscle but intradermally increases the potency of all vaccines. Takes a little bit more skill to do, but certainly something to consider. The other possibility is to use these adjuvants that boost the immune response. I think I would say this is probably, if I had an organ transplant, not something I would want to do for fear of awakening the immune response against the transplant. One thing that the FDA absolutely should be doing is extending the EUA so that people with immunosuppression can take monoclonal antibodies prophylactically. They have not done this yet, but if you are a transplant patient and you feel sick or you get a positive COVID test, run, do not walk to Houston Methodist and get a monoclonal antibody infusion. It can save your life. So in the last couple of minutes, we've talked about vaccines for the last few town halls, and rightly so. Maybe time to answer a couple of other questions relating to treatment and some other things. So some folks were asking about drug therapy, and there are two relatively advanced drugs under investigation for COVID. One is an RNA polymerase inhibitor, and that's called molnupiravir, made by Merck. A very similar mechanism of action to remdesivir or favipiravir. It basically blocks the ability of the virus to reproduce its RNA. The way these kinds of drugs are used in HIV is combination therapy, and I think that's what we'll end up seeing with COVID. The other class of drugs, and these are drugs made by Pfizer, are called protease inhibitors. This one was actually developed against the original SARS virus. And what it does is it also blocks viral replication, but by blocking the virus's unpacking of its proteins. And again, probably to be really effective, this would be given together with a polymerase inhibitor. We've talked a little bit in past sessions about repurposed drugs, already approved drugs that are used for one thing, potentially being effective against COVID. So far, this has not really panned out, except for steroids in hospitalized patients. Remdesivir is a repurposed drug. There's a rheumatoid arthritis drug called baricitinib, and also tocilizumab. Those are somewhat effective in subgroups of patients, or reducing the length of hospitalization by a day or two. Other than steroids, no big home runs here. The other big group of people who we're really trying to find something for, and that's where these Pfizer and Merck drugs could come in, is people who have mild symptoms, positive tests. You want to keep them out of the hospital. So a lot of different things have been tried, are being tried, including ivermectin, budesonide, inhaled budesonide, statins, fluvoxamine, which is an antidepressant. Some interesting data with all of these, nothing conclusive. There are a couple of multi-center clinical trials, either ongoing or starting, that will evaluate some of those drugs in a large group of patients in a very controlled way. So we may get some good news on this before too long. Last topic, masks. It's interesting. I went to Kroger last Saturday, and nobody was wearing a mask. Absolutely nobody, except for, dumb old me. Then I went to Costco on Sunday. Everybody was wearing a mask. And so I think I conclude that people are a little confused. And I think, if you're worried about this or wondering what you should be doing, really it's kind of common sense. There's a few tests, how susceptible are you? Have you been vaccinated? Are you a solid organ transplant recipient? Or are you one of those misguided souls who's healthy but has chosen not to be vaccinated? The more susceptible you are, the more careful you should be. How prevalent is COVID in your community, your neighborhood, your family group, your social circle? The more COVID there is around you, the more careful you should be. What kind of exposure are you, potentially having? Is it, a small group of friends who've all been vaccinated? You really don't need to wear a mask. If you're planning to go to the theater or, an airport, boy, I would wear a mask. Outdoors, not so much. Indoors, a little more dangerous. Quiet sitting together, quiet talking, or something that's aerosol generating, like being at choir practice. Those really are the kinds of questions you should be asking yourself. And I think if you take that kind of common sense approach, it will help you sort through what to do. And then, of course, the other question is, what's the downside? I would really say, if in doubt, wear a mask. I mean, it might be a little uncomfortable, and some of the tougher, more macho people that you run into might look at you a little strange, but so what? So I hope that's helpful in terms of the whole masking issue. And as always, appreciate your being with us today.
Thanks, Dirk, and thanks for that really great common sense advice there at the end, as well as the data around that. I know we'll get to some questions at the end around each of that. So I'm going to go rather quickly today. I want to give you a quick update on where things are, which of course is a much better place in our community. Talk a little bit about the vaccines, particularly our vaccine mandate, which of course has made the news big time around locally as well as around the country. And then just a little bit around our employees and what we're doing to support them. So this is the slide that we've shown many times in terms of people being diagnosed with COVID at Houston Methodist. So the blue bars, I usually spend more time with the orange, which is the percentage of positivity. But I want you to focus on the blue bars. Look how short those are. That's actually very few people getting diagnosed with COVID. And when you run that back across that whole pandemic, it's about as low as you've seen. We're seeing diagnostic levels that are looking like last May before things got out of control, kind of in that pause period in between things. But of course, then when everybody loosened up and acted like it never happened, no one was vaccinated, and even very few people had natural immunity. Now we have, about 50-ish% of our population vaccinated, and we have, of course, many people with some natural immunity as well. So very different situation. We see a similar story. We see a similar story. It's going backwards on me here. Hold on. We see a similar story nationally and see these numbers coming down dramatically. And so when you see these trends, there is one main reason these are happening, and that's because so many people have done the right thing and got vaccinated. Yes, that added to some group of people with natural immunity, but still now far away more of that has happened through the vaccines. And so the vaccines are working. And so the net result is at the hospital level, this is the number of patients in-house, we're at the lowest levels we've seen since last May, which is, something we're all celebrating, and to some of Dr. Miles's points earlier, enables us to fully put our time and attention on the other half of the sacred and I talked about last year, which is focusing on people with other illnesses. And in fact, we are busy, packed, really seeing a huge volume of patients that we are caring for. And unfortunately, as we saw a couple instances there, we still are seeing people with negative sequelae of having delayed their diagnoses, delayed their treatment, etc. And hopefully we'll rapidly get past that as we focus on those individuals. So my key message today, trust the vaccines. And you're going to note that I've been showing this same slide since the beginning of March, and I took a piece off, right? So at the beginning of March, I put in, give us 90 to 120 days. I said, let's get to the month of June, maybe the end of June. Why did I take that off now? Well, I took that off because frankly, we are down to a trickle of new people getting vaccinated. I mean, it's about 600 a day at Houston Methodist for 5 days a week. So it's a very small number. So and our outreach activity is sort of having the same experience. The people who have wanted to get vaccinated, it's not enough people, let me be clear, are getting vaccinated. So at a certain point here, we're about as far as we're going to get, at least until we put kids into the mix and are able to vaccinate children under 12, which I think is going to happen in that September, October timeframe, if I'm guessing, based on what we're seeing in terms of what the manufacturers are saying about that. So trust these vaccines. This is where we are as a country now. Unfortunately, this is uneven in its uptake across the country. So there are some areas of the country that have actually already hit 70% or pretty darn close. There are others that are lagging. We're sort of in the bottom third in Texas. So we're not lagging all the way, but we're hardly blazing the trail, which, frankly is quite distressing to me as a Texan, because surely we can look at the data, look at the common good, and protect each other. But what you see nationally now, if you look at the entire population, we're kind of around that 50%, because of course we still have all the children who are not able to be vaccinated. But look at the numbers, for example, of the elderly population who are so vulnerable. So great progress. We've got more to go, but it is slowing down around the country, has been for a while. It is really slowing down in areas like ours and coming down to not quite a trickle, but pretty darn close to that. This is what you see nationally. I don't have an explanation for why we've upticked a little bit the last week or two. Maybe it's some creative strategies to get people to be vaccinated, and you're seeing lots of creative strategies happening around the country. But look how much we've come down in daily doses. And remember, this is total daily doses. So many of those daily doses right now are reflecting people 3 and 4 weeks ago who got their first dose. So that's what we're seeing at Houston Methodist. We're seeing about 600 right now a day coming in for their first dose, but we're seeing a couple thousand to 3,000 still coming in for their second dose. So beginning of July, it's going to get really, really slow from a vaccination standpoint. And this is our data. We will actually cross 800,000 doses probably next week, which is a phenomenal number, obviously. But as you see here in the blue, which are the first doses, as I've been mentioning, they've gotten to a quite low point. So you've obviously, you'd probably have to be hiding under a rock these days to have not seen some press about the fact that we decided to mandate vaccines. Very, very proud of our institution, proud of our leadership, our physician guidance, our scientific guidance, and proud of our employees who stepped up and did the right thing, because at the end of the day, our goal is to be the safest hospital system anywhere on the planet. I'm very happy we got to well over 99% compliance with our policy. So to put that in perspective, you see in the blue box on the right, the light blue box, I differentiate between full and part-time employees who spend a lot of time here, and then of course PRN, or that's kind of our slang for as needed employees. They may work at 4 different hospital systems and show up here once every 3 months. And so, that's a group of individuals we need and we appreciate, but who, if one of them decides to leave, obviously is less impactful for us. Look at the full-time and part-time employees. The official number when we went Monday night with our deadline was 178. It's actually now 170, because some have stepped up and done their vaccines, whether a first dose or that some of them were finishing their second. And you can actually see out of that group, there's still some people that have gotten first doses, so they'll mostly get compliant during this time. So in spite of all the noise you heard, and boy, a couple people are really good at being really noisy, especially when it's a sexy story. By and large, we are done and we're moving on, and we are moving on knowing we're the safest hospital on the planet. I wanted to share with you, one of the many, many emails I get. Now, I get some crazy emails, let me be clear, but I've been called a lot of names, but those are usually from Poughkeepsie or somewhere really far away that has nothing to do with Houston Methodist. What I hear from our patients and what I hear from the bulk of our staff are, this is great. I am so proud of us for doing this, so glad that Houston Methodist did this. This is a note I got from the CEO of a large hospital system in the Northeast, and I have talked to dozens and dozens and dozens of leadership around the country, basically thanking Houston Methodist for inspiring them to move forward. They haven't moved forward yet. This is not one of the ones that has, but they're moving forward soon, and we have helped pave the way. And what better definition of keeping patients at the center, focusing on our values, focusing on our faith basis, and doing this compassionately, and focusing on our tagline of leading medicine. And so here you see now that the ball's finally rolling, and we were predicting this from the conversations we had, and I have no doubt from talking to others of these institutions that the fact that someone led the way, in this case us, has enabled them to make these decisions and move forward. And as you saw in that last note, I really believe we're going to help save countless lives, potentially not just here but elsewhere, as we push on the vaccines forward. So you see a small system followed quickly in Montana, but then the big news was when Penn Medicine moved forward with its very large employee base. RWJ Barnabas, who's in New Jersey, followed shortly thereafter. University of Louisville, Indiana, University Health, and then just yesterday, a whole conglomeration of a dozen different hospitals in DC announced, Johns Hopkins announced, University of Maryland announced. Now they're all different. Those are particularly the last couple of days are somewhat different flavors of mandates than others along the way have chosen. But the bottom line is you will see the vast majority of health systems mandate. Why? Because it's the right thing to do and it keeps people safe. And I'm really proud of what we've been able to accomplish. Obviously we got a lot of noise. As I said, we had a couple noisy people. We did have some individuals choose to sue us. Last week on Friday, their temporary restraining order, or their request for that, was tossed out by the judge. And that judge made it really, really clear he saw them as endangering the health of other individuals. There's a motion to dismiss at his request that's in place, or in the judge's hands this week, and a hearing tomorrow. So we'll see where that goes. But obviously, we feel very confident. And the bottom line is all the other employees who are now with us have done the right thing. We're moving on, and we are focusing on caring for Houstonians and beyond with healthcare needs. It's interesting because Dirk's shown a lot of this really great data around this. This was an interesting study from the Washington Post. And to cut to the chase of this, what it basically says is that the infection rates that are happening right now in people who are unvaccinated haven't changed all that much over the last 3 months. They're still getting infected. The reason the overall infection rate is so far down is because so many people have been vaccinated, and further proof that the vaccines are working. So let me talk about going forward. We believe in unparalleled safety, quality, service, and innovation. These are our fundamentals that we always focus on. We've been focused throughout, but I don't want to say it was distracted. It was, we must have, had to do the things we had to do for COVID. Now it's really about focusing on those fundamentals, caring for the population, focusing on the future while we continue to have some COVID along the way as well. And one of the things I had talked about back in kind of the September timeframe with our team was, how do we push some of our strategic advantage as an institution? How do we focus on those fundamentals? How do we execute on that sacred and that I talk about? And so you see here, of course, first and foremost, focusing on unparalleled safety, quality, service, and innovation. You also see caring for our people, and we've done that, I think, exceedingly well throughout, even maybe with a little tough love lately around the vaccine, but we didn't lay off, we did not furlough, we did not pay cut a single individual. We have paid repeated bonuses throughout, and we have tended to the psychological, psychiatric, physical, and mental needs and faith-based needs of our team members throughout this entire time. Very proud of of what we've been able to do in that. We'll talk more about this later this year, but you see that as you hear from these experts here, we are aggressively investing in our academic programs and driving forward. We are continuing to drive forward very aggressively with our innovation programs as well. And you'll see lots of announcements. You probably saw one this last month about a land we bought on 290 that we intend to turn into a hospital before too long. And you'll see many other expansion announcements and other things that we are working on to continue to care for the community. I want to focus, though, just a little more on our people. We, recognize them, and as we've talked about here many times, they have been amazing. I mean, in every single way. They're also exhausted. It's been a long, 15-month period, very difficult emotionally, physically, at every step of the way. And really, right now, with the resurgence of care needed and with some of the delays that we've talked about, we need them ever more going forward. And so we are really focusing on how do we care for them, how do we kind of all move past this and move to this new normal. So we announced last week kind of a summer filled of R&R. We took the military rest and recuperation that they know works very well and is critically important for people in the midst of battle, in the midst of war. And we paid a $1,000 bonus to every single employee last week, or it'll actually go out July 2nd. We announced it yesterday. And we are giving out a day of PTO to every single one of those individuals as well. And lots of other great things to do this summer. Actually, today we announced a contest with the Astros. We have a bunch of suites that we're not going to use otherwise this year, but we had to kind of kick back in with. So we are going to use those for employees with an employee contest. We had about 4,000 people enter our contest already today. Many other soft things through the summer, culminating in a fun grand prize. I'm not going to burn that today. As well, though, behind this and behind the scenes, all of the human resources, the psychological support, the spiritual support, other programs that are there for the people that are still having difficulty, for the people who do need to have some help in moving forward and moving on. And so thank you for all of your support. Thank you for all the things you've done to support our people throughout this pandemic. It's made a tremendous impact on all of them. So God bless each of you. Now, we don't have tons of questions today, but we have a few. So I'm going to move us to a few of the questions. And I think Dr. Sostman is going to be the star of these. So Dr. Sostman, I'm going to turn to you and start asking you a couple questions. You've covered some of these, so I'll try to move quickly. But one specific question: if somebody's had COVID and along the way they got monoclonal antibody treatment, should they get vaccinated, and what's the timing on that?
Yes, they should get vaccinated. They should wait 90 days after the time they got the monoclonals to let those monoclonals get out of their system so they don't interfere with the vaccination.
And you showed that one graph. I hadn't seen it before, the cluster of the green dots and the purple dots, right? And you showed how impressive that kind of journey is. And one of my takeaways, now I'm parsing together a couple studies, but our internal study said basically for people who've only had one vaccine, it was 64% effective at preventing death. If they had both right, we'd knocked out 99%, and that was kind of that middle box for the people who've been vaccinated. Right. But for the people who've had COVID, that's the left box. So
that's right, yeah.
If I'm jumping to conclusions here, but if I draw sort of an analogy here, I would expect that those individuals, based on that, have a higher risk of death than somebody who actually goes and gets at least one shot who's had COVID before.
Yeah.
Does that make sense?
Yeah.
So get your shots if you have had COVID. It's still debatable, I think, is one of the things you were saying about whether you need that second shot or not. We've chosen to follow CDC guidance internally, and we are still doing that. But that's something I think we may see some evolving guidance around, I suspect.
Yeah, I mean, having COVID definitely protects you compared to somebody who's never had COVID or been vaccinated, but it's not as good as getting vaccinated.
Okay, well, we have another question here, and I know many of you, either your workplaces have gone back or they're contemplating going back. This is a conversation set we all have very frequently with others. So this one comes in specifically about saying, okay, so we have some employees who were diagnosed, 6 months ago-ish with COVID, and they don't want to get the vaccine, kind of to the, discussion we were just having, they should, and they feel like, they're protected. But is that enough to allow them to come back to work in an office setting? What's your advice to somebody who is running a business like that, has employees like that?
I really think you should require them to be vaccinated. I mean, there's almost no downside. It is more protective. I think it's also, from a social standpoint, if everybody in the office is on the same page, they've all been vaccinated. They've all, kind of said, I'm going to protect my coworkers. It's just a good thing.
Okay, and I get a lot of, I talk to a lot of people out there. What I've seen many businesses do, who are not mandating vaccine by and large, they are oftentimes mandating regular testing intervals, oftentimes very frequent, even weekly testing intervals for people who choose not to be vaccinated, because really it poses a really tough question, right, when you're putting people together in a conference room and, 8 of them are vaccinated and 2 aren't, and how you handle those kinds of questions.
Yeah, that's right. And certainly there are religious and medical reasons to not get vaccinated, and those have to be respected. But folks who are not vaccinated, really, they should wear a mask all the time. They should get tested frequently. They should work remotely to the extent that's possible. Because they do pose a risk to their coworkers.
Right. Okay, well, I'm gonna take the next question, which was a question about, as we continue to have increased vaccination rates, and of course now at Houston Methodist we have 100% of our people are compliant with that, and let me just say that that's about 2% of our people who either had an exemption or a deferral, about half and half between that. So the deferrals for some women who are pregnant who wanted to wait till afterwards. So essentially everybody vaccinated in that situation. Of course, getting to be 50% of the population as we age up in the population, it's higher percentages. As you look at people who are more likely to use healthcare, they're more likely to be vaccinated as well. So the questions around access to our campuses, do we think those are going to be permanently different? Do we think those are going to change for the better? And I think you're going to see us probably return to a more normal situation far more quickly than other institutions are able to do. I'll give you an example, and I know my father will be very happy about this. We just announced we're returning to pet visitation as part of our volunteer activities now. We've changed some of the access into the professional buildings so far. We have some different, changing guidance for employees. However, you should expect that masks will be a part of what we do within a healthcare system for a long foreseeable future, because we know that they work, we know that they're effective, and of course, Dirk showed great data, disturbing data, but excellent data that supports the fact that unfortunately some of the most vulnerable, transplant patients and others, just aren't having the antibody response we'd like them to have. Not surprisingly, right? So this is why herd immunity is so important, why all of us getting vaccinated is so important, to protect each other, not just protecting ourselves. So stay tuned. We will continue to very logically, thoughtfully release things and loosen things up as it makes sense, always with the safety of our patients at the first and foremost. Okay, Dirk, I think you covered this pretty actively, which is this booster shot question. I think your synopsis is much less likely in the kind of fall time frame that a lot of people talked about. Is that fair? And much more likely a year or 2 out or something like that?
That's what it's seeming to look like. I was back when we were going at this hot and heavy, I was pretty sure we were going to need COVID boosters during the upcoming flu season, but so far it doesn't seem like that's going to be necessary this year. Yeah.
So we'll cross our fingers.
Crossed.
Of course, there's 2 reasons to potentially have a booster shot, like Dirk talked about. One is waning immunity, which we keep getting good information about, and encouraging information that says the immunity's holding. Of course, it's not physically possible to have 3 years of data on that, so we don't know all the answer to that. And then the other, of course, is the virus changing and then needing something to boost the immunity against a different virus. So here's a specific question about booster shots, and this is somebody who has some travel planned. They were an early vaccinator, so back in January that they got vaccinated. What do you think? Are they going to need a booster for travel internationally if they're traveling end of this year, beginning of next year?
If I had insight into the vagaries of government health bureaucracies, I would be a happy guy. But I think it's quite possible that you'll end up having to get vaccinated again, not because your immunity has waned, but because there's a regulation. I know the European Union is talking about 6 months, that their vaccination certificate will only be good for 6 months after you get vaccinated. I would expect that's going to get extended as the data on follow-up and safety and so forth gets longer. But you're just going to have to watch the news, watch the government websites, and so forth.
And it most definitely may vary dramatically by where you're going.
Based on which country you're going to.
And a multi-country trip may be ridiculously complicated. So those are the kinds of things. I mean, you're just going to have to spend a lot of time and be very careful. We'll be there for you if you need booster shots. And in fact, this next question is, how are we going to handle booster shots if needed? How are we, where are we going to do those? I think that's to be determined still, most likely, because I would assume we're going to be doing mass vaccination activities for a booster shot that will probably structure something pretty similar to what we have now, and that's still in place now, but of course is going to start slowly unwinding over the next couple of months. But again, I don't know that for sure. I would hope that when that happens, there's sort of more breadth of ability to respond. Maybe we don't have the deep cold requirements and other things, and so maybe simultaneously you get it to the hospital systems, to the pharmacies, to the everybody else. We do this with flu every year, right? I mean, from September to end of the calendar year, but then even into the winter, we vaccinate 170 million people for the flu across the United States, with the bulk of it happening kind of in that September, October, November, December kind of time frame, although some of it on the tail. This can be done very rapidly if the supply chain is there and if we use the delivery mechanism. So stay tuned, but I can tell you we will most definitely be a huge part of that. Okay, here's a question about vaccine efficacy. I gotta be honest, I had to read it a couple times to try and understand exactly what was being asked, because they're saying right now we calculate efficacy based on sort of simple how many affected patients to a sample size during the trials. Are there any other ways that that's being calculated now that may be a little more detail-oriented, sophisticated that you know of?
In people, not really. There are some trials going on now where they regularly do PCR testing, to see if they've converted to positive or not. Certainly in the research lab, and these are things that are just not feasible to do routinely in patients. There's virus neutralization assays, there's cell immunity assays and so forth that can give you there's challenge virus challenge studies in non-human primates and other experimental animals, but really in people it's all based on either developing symptomatic illness or developing a positive PCR test.
Okay, and so, all right, I think we want your crystal ball now. So somebody's asking, polish it off. What do you see as the likelihood we may end up with a problematic variant, coming into Houston and being difficult to control?
I think it's pretty unlikely. That's not zero. You never know what Mother Nature has in store for you, as we in Houston know very well from our weather. But these viruses tend to change in a sort of stepwise fashion. At least we here at Methodist, and God bless our Department of Pathology and Genomic Medicine, Dr. Musser, Dr. Long, Dr. Bernard, and that whole group of wonderful individuals. We have a really good handle on the composition of the different variants and how they're changing in the population. So I think we're going to have a pretty good advance warning if something really dramatic is coming down at us. Then the issue is going to be, how fast can the pharmaceutical companies adapt to it.
And right now, at least with the mRNA vaccines, they're saying, 2-3 months. They think we can have a booster really out in production, starting to get to people. And the FDA has at least signaled they'll move quickly for those kinds of things. So, yeah, I agree with your assessment. And we, knock wood, have not seen something, that's, in spite of obviously, hundreds of millions of cases, right? And the ability for this virus to have mutated, it has not thankfully done that. But it is continuing to mutate and continue to spread, obviously, throughout much of the world. One of the challenges we have around the vaccine now, and one of the things I will be honest, I'm very frustrated with as I watch our uptake dwindle in this wealthy, successful country that's managed to push this down, and not at Houston Methodist, but many places starting to see some wasted vaccine. From altruistic reasons, we need to be helping the rest of the world, but from selfish reasons, we need to be helping the rest of the world also, because it's going to run the risk of getting out of control for us if we have this
absolutely.
Go throughout.
And you see, where these variants are coming is the countries that have not been able to vaccinate the population. And I think the saying that nobody's safe until everybody is safe is really pretty accurate.
Mm-hmm. Well, before I come to this question, I see one coming up on the board that I think is a useful one to ask now, and it's for those who are unvaccinated, kind of one of the predominant arguments has been, well, I don't know about these mRNA vaccines and their long-term effects. What do you answer? How do you answer that?
Well, first of all, there's almost no vaccine that really has long-term ill effects. They tend to be seen in 6 to 8 weeks. The one thing that can be sort of seen a little bit longer is antibody-dependent enhancement, where you get these kind of, not neutralizing antibodies that actually, if you get reinfected, help the virus get into your cells. No evidence whatsoever that happens with COVID or with the messenger RNA vaccines. Beyond that,
Right. So what you're saying is the reality is the window has closed at this point for the vast majority of conceivable side effects
the
from these
Guillain-Barré, the transverse myelitis, the feathers growing out of your ears, that's.
I think this is metal. It may be sticking to my head, but
That's right.
yeah. So I mean, there's a lot of crazy stuff out there, unfortunately. But the bottom line is, we know they're safe, and there's really no plausible scientific, biological reason to expect any longer-term ill effects. I mean, we just don't.
Correct,
don't see
because that messenger RNA is gone in less than a day.
No. Okay, so I'm going to talk briefly about this. If y'all really want to ask me this question, you have to take me out and buy me a beer. Then you're going to get the honest answers. But this is, what are the lessons learned from this pandemic? I think first and foremost, we as a world totally unprepared, right? In spite of lots of shots across the bow, basically from microorganisms, 2 different types of related viruses to this, from SARS and MERS, obviously Ebola a few years ago. We have underinvested in public health at the federal level. We've been underinvested in public health at the state level, at the local level. Really great people working there, but not enough of them, not enough resources, and not enough ability to do that. So, the number one lesson coming out of this, to me, is that we have to figure out how to change that dynamic. We have to have the surveillance programs in place. We have to have the potential treatments on a shelf ready to go. We have to be speculating and scientifically about which infectious diseases could do this. There are ways to do some more universal type vaccines or potential vaccines, even if it's something that's only slightly helpful early on. We got lucky lucky here because remdesivir was helpful, and it had nothing to do with COVID. It wasn't created for COVID. It was on the shelf because it had been worked on previously. A number two correlate one to that is I don't think we can all rely just on government to do that. It's one of the reasons why at Houston Methodist we are building a center of excellence in infectious diseases and pandemic preparedness. We've helped lead the way with that in our community here, working in collaboration with many other wonderful institutions and the local government. But I think we can do even better next time, and part of that's going to be that investment in that preparedness. And then the third, and I've got to say, this is when the frustrated part of me comes out, and this is where you're going to have to get a couple beers into me if you really want to get me venting. We societally have to figure out how we're going to once again trust in science, how we're going to stay anchored in the science, in the facts, and not get caught up on sort of the political side or really the misinformation side. We have seen that at every single step of this pandemic, and it's cost countless lives as a result. There's no ifs, ands, or buts about that, no way around that. There's a way to do that, but we've got to figure out what we're going to do societally with that. So I'll stop my soapbox there and move on to one last question for Dirk. This was kind of how you ended as well, which is, why is it okay sometimes to not wear a mask around others, and kind of talk a little bit more about that decision tree you have for wearing a mask?
Well, there's two reasons to wear a mask. One is to protect yourself. The other is to protect those around you. If you've been vaccinated, your chances of infecting somebody else are really very slim. Maybe not none, but very slim. And that would be the answer to the question of why maybe you don't have to wear a mask if you've been vaccinated and others have not. Personally, if I were around others who have not been vaccinated, I would still wear a mask, just out of respect for them. And if I could join you on the soapbox for a moment. I think the other thing that we need to have as a discussion as a society is where do individual rights start and stop. I'm a big believer in individual rights. But if your individual right includes the ability to infect and kill me and my family, I really kind of don't buy that. So I think what you do to yourself, the risks you take for yourself, absolutely, those are 100% on you. When your behavior starts putting me and my family at risk, different story. And I think that's something that I don't know if we'll ever get there, but we ought to be talking about. So I would wear a mask around the unvaccinated.
And this question that was here really is about that very question. And I think, your slide there in the detail is very similar to some things I'd talked about in a different way before. I mean, really, you have to assess your own personal risk. You have to assess, which is, are you elderly? Do you have people around you who are elderly or who have risk? You have to assess your own risk tolerance. And now, fortunately, that is, an assessment that's a little easier because, of course, we see much less COVID out in the community. And you have to think about others, to your point, about where do those rights start and stop. And so in a large group setting still, when you don't know who's vaccinated, who's not vaccinated, who might be the transplant patient right next to you who is wearing a mask because they're deadly afraid of getting sick and should, and for good cause they're worried about it. Why wouldn't you wear a mask to protect those individuals in those kinds of settings? Okay, so I'm going to have one last question. Dr. Niravath, I'm going to put you on the spot because it came in here over the chat, and that's, does COVID or potentially the vaccine, either one of them, have any adverse effects on cancer cells?
Yes, this is actually a really interesting question. We don't know that, we don't know the complete answer to that, I guess is one way to say that. But from all the data that we have, there have been cancer patients that were included in the initial COVID vaccination studies. And it doesn't feel like either one affects the other in any significant way. So meaning that as far as we know, no, COVID does not affect the cancer cells, and most likely the cancer is not affecting the COVID vaccination from being effective either.
Perfect, thank you. Well, and I'm going to take one last one on the way out, just came in also, which was a question about someone's child. I don't know the age of the child, but it states they have bad allergies, and should they take the vaccine or not? First off, talk to your pediatrician, talk to your physician if you have individual concerns, because of course I can't give you advice on the specifics, and I don't know the specifics. But to give you sort of the general advice we have for any individual, whether a child or an adult, allergies that are severe, like an anaphylactic reaction to an injectable medication, for instance, people who've had anaphylactic reactions to something else, first off, the one who's had it to an injectable, we're probably going to say that's a hard, fast contraindication, don't get vaccinated. Other types of anaphylactic reactions or significant allergic reactions, we're probably going to watch them a little more closely in most cases. So with your individual child, talk to your pediatrician. I'm going to bet more likely than not the answer is going to be yes, go ahead and get vaccinated, but do check with them for their medical advice. So with that, I'm going to bring things to a close. I want to thank everybody for being here today. It was really a great session. We're going to take the month of July off from these and give somebody some summer, part of our R&R that we've talked about, including for the great people that y'all don't get to see behind the cameras, who I'm looking at each of them, thanking them for the great job they do day in, day out through all of this. In August, on August 12th, we're going to come back. We're going to actually have Debbie Sukin, who runs our Woodlands Hospital, is one of our regional senior vice presidents, and Chris Siebenaller, who runs our Sugarland and handles the South region for us as a regional senior vice president, talking about much of what's happening throughout the system, our response, but also our plans going forward in the future. So we look forward to seeing you then. Have a great summer, and we'll see you soon.